want to introduce our speaker today, Dr. Trice. Dr. Kevin Trice is the medical director of adult sleep at Norton Hospital. He is a native of Louisville, Kentucky. He's married and has 3 kids. His passions include medicine and technology, and he's really looking forward to speaking to us today and talking about all the sleep disorders and the things that we can do therapeutically for them. So without further ado, go ahead and take it away, Dr. Trice.
Good afternoon, everyone. As you said, my name is Kevin Trice. I'm a sleep doctor here at Norton Healthcare. I'm the medical director for adult sleep medicine, and I'm going to talk to you a little bit about sleep apnea in general, and then hopefully give you some other little tips about how to make things work a little bit smoother in your offices. And I don't know, McKenna, if you can share your screen. I'm sorry, I'm logged onto a Norton computer, but it's not allowing me to do any sharing of my screen.
Can you see the slides?
See. I can see it now. Can everyone see those slides?
Yes.
Everyone's there? Okay, great. Let me see if I can turn this on to full presentation mode. All right, so we're going to jump right in here. So just some couple of things here. Now, one little caveat, just so most patients know, you can go on to the next slide, is I am a board certified pulmonary critical care doctor. I do not practice any pulmonary medicine whatsoever. So if you get excited by the talk, please don't send me any pulmonary consults. What we're going to talk about today is sleep apnea pathology, how it happens, what can be done in the primary care setting by both physicians and nurse practitioners to do a good workup in terms of evaluating and screening patients, and then at the end a little bit about the actual testing process, what to order, and then what happens when the results come back. You can move to the next slide. So sleep apnea is kind of a generic term, and the more official term is sleep disordered breathing. I think that kind of gives you a better idea of really what's happening. We define an apnea by looking at specific metrics. So apnea meaning no breath or absence of breath. And this is measured by a couple of things. It has to be on the EEG when we're looking at these belts on the chest to see how the chest wall is moving. You're going to be looking at least 10 seconds in duration where there's a reduction in flow. We use a thermal sensor to measure flow. So that reduction has to be at least 90%. You want to see the person is trying to breathe, but they have a reduction in flow for at least 10 seconds. And when we look at these waveforms, it has to meet criteria for the majority of the waveform. In other words, it can't be kind of a bad signal. When you see that in a patient, they're trying to breathe, but they have very little flow, that is an obstructive event. So I like to describe to my patients, this is an example of what happens if you choke someone or they're choking on food. They're trying to breathe, but nothing's getting through the windpipe into the lower lungs, compared to central sleep apnea, where the person's not trying to breathe. And this would be more consistent with, for instance, someone who's had a drug overdose of heroin or narcotics or benzodiazepines or post-surgical options. There will be no effort to breathe whatsoever. Next slide. So again, kind of getting a better picture of this, when you look at an obstructive apnea, here in the middle, you will see a reduction in airflow. You will see that when we measure pressure inside the esophagus, there is this increasing negative pressure. In other words, an inspiratory effort. So they're sucking in air and they're trying. The effort is getting higher and higher and higher and higher. But despite that, their oxygenation is going down because there's no flow getting past the windpipe to the lungs. In a central apnea, again, there's no airflow, but there's no effort. The person's not trying. This is someone who's literally not breathing. And then a mixed apnea is where you can have a little bit of both. Here in the beginning, you'll see that there's no effort. What would have been a central apnea or a pause in actual breathing, followed by an attempt to breathe. And because this waveform, 90% of it did not meet the criteria, you can't call it an obstructive apnea. And this is a mix, both central and obstructive. Key is that it's about 90% airflow reduction. What I call it is stopping breathing. Most people think of this as like a flat line on an EKG, versus an hypopnea, which is more like an irregularity. So there's still a reduction in flow, but it's only 30 to 50%. So a baby apnea of sorts. They're trying, not as much flow reduction, but again, it is associated with the drop in your oxygen saturation no matter what. That's very crucial. Sometimes we'll see these drops without reduction in oxygenation, and we can call that a respiratory effort-related apnea. They're trying is an apnea, but their oxygenation is enough. Next slide, please. So how do we define obstructive sleep apnea? There are some clinical indications you can look for, things you can get from your history, and then also things we look on testing. So one of the key symptoms is someone who has excessive daytime sleepiness. And I say excessive because sometimes patients will tell you they have very little daytime sleepiness, or they're doing things to augment their daytime sleepiness in the form of either caffeine, other medications, sometimes just flat out denial, or they're just keeping themselves physically busy to ignore the fact that they're having symptoms. So the functional impairment is really important. Some patients will complain of impairment, other patients will deny it. So it's really important to tease out if it's interrupting their daytime function. It's not just sleepiness. It could be in the settings of mental clarity, of memory issues, confusion, concentration issues, and we'll get into some other ones in just a bit here. So when we look at testing this and actually defining it and giving it some value so that we can quantify how severe it is, we look at two things, particularly the AHI, which you'll see frequently, which is an apnea-hypopnea index. In other words, the number of apneas plus the number of hypopneas that happen over an hour, with a cutoff of 5 being less than 5 being normal. The respiratory disturbance index is almost the same. It can include those RIRAs, those little drops in effort that aren't necessarily associated with oxygenation issues. And this is something that's used kind of in an older model. We don't use it as much anymore, but it can show you patients who may be borderline with their AHI, but still have some functional impairment because they're having these efforts related to the evening that could also result in more arousals, and they can have more functional limitations and even have a negative, quote, sleep test. Again, normal is going to be less than 5 events per hour while sleeping with continued respiratory effort. If it's more than 15, we're going to get into that being positive for everybody, even if they require, or admit to having no functional impairments. Somebody comes to you and say, Doc, I'm perfectly fine. I have no problems, but my issue is 16. We should do that. Sorry, let's take the chat off there. Next slide, please. So who does this affect? We know that looking at population dynamics and population studies, it's somewhere between 3 and 7% of the general population. Of course, it can be higher in specific populations. So if you just stop for a second and think about how many patients you see in a week, and let's just say you see 25 patients a day, you work 5 days a week, so you've got 125 patients. And so you're going to see 3 or 4 a week easily that should have sleep apnea. In other words, 1 in 15 adults will even have moderate sleep or severe sleep apnea. And that's important because that means you should be seeing these patients almost every single day. Now, some of them have been treated or diagnosed, but many have not been. What are some of the factors that would make you think the patient's more likely to have it? Well, we have cisgender males, those who are male, and also transgender male if they're on hormones, more than female. It can also be postmenopausal female. Their rates actually start to approximate that of males. If someone is obese, if they have a small mandible or jawbone, or a recessed maxilla, similar to Jay Leno. So Jay Leno is known for having his prominent chin, but actually one of his biggest issues is not that his chin is so large, it's that his midface is sunken in, his maxilla is hypoplastic. If they're over age 40, if there's a strong family history, or if they have certain disorders like hypothyroidism and acromegaly, and that kind of makes sense for those. Next slide. So a couple of examples. When you look at these people, you think, maybe 1, maybe 2, but not all of those would think of obstructive sleep apnea. When you're looking at Reggie White, this is someone who died, we think, prematurely, who was known to have severe untreated obstructive sleep apnea. Risk factors, of course, he's over 40, overweight. You can also look at neck size, one of the measurements that we can measure. So in men greater than 17 inches is a risk factor, similar here to John Candy, the actor and comedian. But also here, when you look at Princess Leia, in my mind, you can see sometimes a smaller mandible. And so sometimes this is just an example of a craniofacial structure. Hers is very mild. That should prompt you to think about patients may have symptoms. Next slide, please. So one thing I think that's really important about sleep apnea is some people tend to think of it as a sleeping disorder. And I tend to think of it as a series of symptoms that tell me that something else is going on. We know that sleep apnea can be associated with multiple different disease states here at the bottom, including those with mild, moderate, or advanced renal disease, those who've had a stroke, which is a definite indication for getting a sleep study, particularly if they've had a stroke within the last 30 days. Anybody who has a myocardial infarction or even angina should be tested. Certain arrhythmias, particularly supraventricular tachycardia and atrial fibrillation. Again, these are guidelines at this point. Patients with associated heart failure, particularly those who have reduced ejection fraction, but even those who have preserved ejection fraction after an episode, should have in-laboratory testing, not home testing. We know hypertension, whether it's systemic or pulmonary, particularly if they're on 2 or more medications or have difficult to control hypertension. These are things that should be automatic that you should send them for evaluation. A lot of us, particularly in the pulmonary space, tend to think of the sleeping issues. Low oxygen, followed by reoxygenation in the cyclical pattern. The person has a history of hypercapnia, they had respiratory failure, may have had a need for BiPAP or hospitalization, they have COPD or asthma. If they have frequent arousals at night, they tell you I have fragmented sleep or I get up several times to go to the restroom. I'm gonna say that again, getting up at night to go to the restroom in my mind is sleep apnea until proven otherwise. I don't care if you have a prostate, I don't care if you're diabetic, I don't care if you're on a water pill. If you get up several times per night, you really should be getting your patients tested. Or patients complain of this non-restorative sleep and having sleep deprivation. We know that these particular symptoms, when we look at what really happens in terms of disease, you're getting an activation of your sympathetic system during the nighttime, as opposed to having lowering of your blood pressure, lowering of your heart rate during normal sleep. You're actually getting surges of adrenaline that will cause increase in blood pressure, increase in heart rate, and more arousals as the adrenaline surges. This will end up in left atrial enlargement, endothelial dysfunction, more overall inflammation, and does increase your chance of having a coagulopathy. Ultimately, look at all these as an increased risk of sudden death, and would like to say these are generally preventable if you test them early, or at least you can make them better if you get them on treatment, no matter when you test them. Next slide. So this is a case example, and I'm going to click on this YouTube video. If you can click on that, we're going to look at a prolonged central apnea followed by gasping, and then we'll come back to this. We'll move forward. Not sure if you can flip over to the next screen and pull it up, share a different screen. And if not, I'll tell you about this video, and you should be able to and you may have to go out of PowerPoint altogether and just go to the internet. Yep. Should be able to get this in. This is a great example.
Did you want to say something before I play it?
Yeah, go ahead. No, go ahead. Go right and let it play. You can turn it off. Awesome. Let me go back to the slide. You can go to the next slide. This is an example of a prolonged central apnea. And I think it's important, this should say work up on the screen, by the way. That's a very good example of what our patients' bed partners sometimes see. So we hear these stories, but we don't realize how severe these patients can be. And this person may or may not tell you that they have any issues whatsoever. So when you're working up a patient, what do you need? The first thing is a good sleep history, and this is really vital on every patient. It's vital because it can help you decide if they need to have in-laboratory testing versus they're a candidate for home testing versus they're a candidate for evaluation by a sleep physician for other types of sleep disorders, whether it's sleep disordered breathing, whether it's a sleep-related movement disorder, whether it's a hypersomnia or a problem of insomnia or parasomnias like sleepwalking and sleep talking and nighttime eating. So there are a lot of reasons why we can see your patients outside of just obstructive sleep apnea. As I mentioned just briefly, physical examination is crucial. So we're looking at, is the patient obese? Do they have a large neck? Do they have a hypoplastic mandible? In other words, a bad overbite, which we typically say. Do they have a hypoplastic maxilla or mid-face regression, looking at their upper airway anatomy with both the Mallampati and Friedman. Is their airway crowded? Do we see lingular ridges? Do we see crowding of the teeth or internal rotation of the teeth? Are you able to see all of the soft palate, including the uvula? Do they have elevated blood pressure? And then once looking at our physical, both on our physical examination and some of our data, making sure they have appropriate sleep questionnaires, which of course we can do, the most common being the Epworth Sleepiness Scale score, 8 questions, 24 points, which can objectify someone's sleepiness. There are other ones that can be beneficial, like a PHQ-9 or an insomnia severity index scale for those who have insomnia, and some of the comorbid conditions that we looked at earlier. Again, we talked about obesity, diabetes, heart failure, arrhythmias, mental delay, seizure within the last 30 days, or recent stroke. These are things we really want to be looking at our workup. Next slide, please. So when you're looking at your sleep history, what are you going to be asking about? You're going to ask these, and I just suggest that you really put these into a smart phrase, and if somebody says, I'm having some sleeping issues, drop down and start checking boxes. Are they snoring? And that may be something they noticed because they kind of choke and catch themselves on the couch and realize they're the only person in the room, or they happen in the middle of the night. Are there witnessed apneas by a bed partner or a family member or in a post-surgical suite? So sometimes they'll be referred from endoscopy after having a colonoscopy or upper endoscopy. They'll say they stopped breathing or had hypoxia, difficulty waking up after anesthesia. Do they gasp in the middle of the night and feel the need to sit up? Do they feel their heart racing when that happens? Are they tired during the day? And here I try to tease out between sleepiness, in other words, if I leave the room for 30 minutes, will you fall asleep? Or just fatigue, which can be a whole host of issues. Are they complaining of fragmented nighttime sleep? Do they get up several times per night to go to the restroom? Are they sweating on the pillow? Do they toss and turn frequently? Are their sheets disheveled when they wake up? When they wake up in the morning, do they feel refreshed and ready to go? Or no matter how much sleep they get, they never feel like their former selves? Of course, that sounds like all of us. Are they complaining of brain fog? You know, it takes me a couple of coffees or an hour and a half to get going in the morning. As I mentioned before, are they sweating on the pillow in the shawl pattern? Do they have headaches in the morning? So it's particularly frontal headaches, from let's say from eyebrow to eyebrow, that tends to go away with mid-morning. That could be suggestive of hypoxia in the nighttime. Are they having decreased libido, decreased desire for intimacy? This can also be associated with it. Of note, I will mention certain medications you really want to pay attention to. Caffeine, which can be, of course, coffee, tea, sodas. It can be add-ins. It can be energy drinks. It can be caffeine pills. Any type of sleep aid over the counter. You have to be cautious. People are using powders, now pills. And, of course, marijuana, which can be both in cigarette form. It can be in edibles, both gummies and brownies, and all types, and even other preparations now in lotions and all type of topical preparations as well. Next slide, please. The Epworth Sleepiness Scale score is something you can easily put in. This is an EPIC. It can be done in the rooming chart. So if someone's coming to you with a history of daytime sleepiness or sleep fragmentation, this can actually be entered by your medical assistant before you actually come into the room. This is for adults only. There's a modified version called the Epworth Sleepiness Scale CHAD or ESS-CHAD that can be used for adolescents. The cutoffs here at the bottom of 10 over 24, that's normal. Anything greater than 10, abnormal. Above 18, you're looking at considering other hypersomnia disorders. So, of course, narcolepsy, idiopathic hypersomnolence, or severe sleep deprivation or inadequate total sleep time, which is something we frequently see, particularly in younger populations. Next slide, please. So, high risk, patients who have a long family history, who have medical problems that are there. We mentioned some of these. I'm putting them again because I think these are very important. These are the people that we see frequently. So again, whether they tell you, no, I'm fine, I don't have any issues at all, some of these are automatic. Refractory hypertension, type 2 diabetes, heart failure, atrial fibrillation, automatic. Automatic, they should be referred. Some pregnant patients, because of course with a gravid uterus, along with the weight gain and changes in hormones, they will have reduction in their lower esophageal sphincter, more reflux disease. So those are complaining of persistent reflux, particularly at night. They'll have smaller tidal volumes, total lung capacity, and weakness in their breathing muscles. They're more likely to develop apneas. And those, of course, who smoke because of the effects of nicotine on the upper airway being very similar. Next slide, please. So One of the best things about treating sleep apnea, since we're using in the vast majority of patients an air compressor, is that there's no real side effects. Now, I'll come back to that because there's been a recall. But if you look at patients, particularly with diabetes, not only can you improve their apnea events, their sleepiness, their chance of car accidents, but you can also improve their blood sugar. So diabetic patients, this is important because it helps to not only lower, but also lower the variation of blood sugar. So that's less medication for a patient. Next slide, please. So we mentioned that physical exam a minute ago. I'm going to just kind of give you a little bit extra pictures here. This one down here is pretty easy. This person clearly has an obstruction in the neck, which is going to impede their ability to breathe, particularly when they're lying supine. That's an easy one. This is also pretty easy. Somebody comes in for surgery, they're doing an anesthesia evaluation, they look there, they can see nothing. This is going to be a difficult intubation, possibly a difficult extubation, and you really worry about flow postoperatively once that tube is moved. But other patients, you could look and see somebody who has allergies, who has tongue swelling, like this one, a large tongue, Down syndrome, for instance, and they have this tongue ridging or lingual ridging. So at rest, this person's tongue is literally resting against the teeth to a point where it's leaving indentation. And when you ask the patient to stick their tongue out, just barely, you'll see this sometimes, and within a few seconds, as the blood flow redistributes, these ridges will go away. So you have to look immediately to see, but if you see that, that's a good sign that there's crowding in the upper or in the anterior oral pharynx, and that's a good sign that there may be some obstruction there, particularly, again, when supine and when their muscles are relaxed. Next slide, please. So Pierre-Robin syndrome, this is something that happens in children we see. I do treat children, but not many, just because we have a pediatric center that does a great job here. And this is characterized by this, again, hypoplastic mandible. You can see where the jaw should be. This L-shaped mandible or jawbone did not grow. Both segments of the bone before the joint were smaller. So not only does the jaw move back, but it tends to move up. And one of the things you'll see this in adults, patients who've had severe hypoplastic mandibles, is that the angle here, so the thyroid mental angle here becomes more open. It should be flat here. And the more this becomes vertical, the more hypoplastic, and you'll see a straight line between the incisors here and the thyroid gland. When you see that, your patient should be tested, even if they're very thin. And I promise me, if you ask them, they'll tell you, oh yeah, when I put my head back, if I fall asleep on a short back couch, I wake up and my throat is sore. So it tends to cause an arching of the palate here as well, and that pushes the tongue up and blocks the airway here. Next slide. So I talked about the Mallampati here, which is with the tongue protruded. You do not ask the patient to say ah out loud. That move will raise the palate, the soft palate, and artificially lower the Mallampati. So it could be a 3 here, really longer use the 4. I still do it for documentation since most people are aware of it. But if you say ah, you could come down to this level and artificially make the patient look better than they are. I actually like the Friedman position better. This is with the tongue still in there, and you're looking to evaluate both the palatal glossal and the palatal glossal in the front, the palatopharyngeal arches, the uvula, the palatine tonsils, the back of the tongue, and looking to see how much of the soft palate is visible. Next slide, please. So what do we do with sleep testing? So this is a good picture or schematic of an in-laboratory polysomnography or overnight sleep test. There's an oximeter on the finger. There are these thorax and abdominal or thoraco-abdominal belts, which are elastic and stretch and have sensors built into them like a little Z that test for excursion of the chest and abdomen to see how far, how frequent, and if it is together or if there's paradoxical movement. There are EMGs on the chin, looking for tension, which should relax during REM sleep. Multiple ones on the scalp, EOGs on the eyes, and there are usually 2 thermal, both an end-tidal CO2 and a thermal sensor in the nose. There's also EKG leads and EMG leads on the forearms or legs, looking for things like periodic limb movement disease. So this is a complex one. One of the benefits is that we can watch the patient. There are actually EEG leads. We can actually measure sleep compared to home sleep tests. And so if you're worried about other disorders like seizures or REM behavior disorder, you can't really diagnose REM behavior disorder well without looking at REM sleep. So you really want to be able to test the patients for that. Home sleep testing is very different. It has none of these up here. It does have a flow sensor here in the nose, a cannula, an oxygen meter, usually a belt here with associated EKG and nothing on the arms or legs. Something we frequently see are portable monitoring or overnight oximetries. These really can't be used to diagnose sleep apnea, always say if they're going to do an overnight oximetry, why not do an overnight home sleep test? To me, this is just a waste of money in the beginning. There are very few indications for doing it after appropriate sleep testing if the patient shows signs of nocturnal hypoxia, in other words, low oxygen night, without evidence of sleep disorder breathing. So your person may have a difficulty with diffusion of oxygen, maybe somebody with COPD or other underlying lung disorders. They have no problem getting air in. There's not a problem of airflow. There's a problem of diffusion. And since they may benefit from getting supplemental oxygen. Next slide, please. So home sleep testing, way less intrusive. This is one of the models, something similar we use. You've got an attachment for your oximeter here. You've got an actigraph, which is measuring position. You're also measuring flow here through a cannula, and there's a built-in EKG on this as well. This is an older model, so this is, you can see, a lot less intrusive. It is good enough for most patients, and some of the newer ones actually have just an oximeter here, along with a watch and one wire that comes to the sternal notch here, and that's it. So nothing on the face whatsoever. It can be done in one night or 2 consecutive nights. There's not much benefit of doing 2 consecutive nights versus 1, so usually 1 is sufficient. There are now almost hundreds of different types of them out there, and they can measure different things. Airflow, here in the nose, oxygenation at the fingertip, a limited EKG, chest and abdominal wall movements, EKG. Some of them have adapters for chain of command to make sure you're using the right patient, they're not putting on a spouse. Some of them have a limited EOG, which may be required for FAA or DOT, depending on the company. And the cost is significantly less. I believe the cost here is around $400. Some insurance requires these to be done first prior to any in-laboratory testing, unless there's adequate documentation as to why a home sleep test is contraindicated. Next slide, please. So what are some of those contraindications? As of yet, home sleep testing is not indicated in children and adolescents. Somebody who may have difficulty understanding how to put the therapy on at home without help. So in other words, they need a sleep tech to walk them through it. If they have COPD with an FEV1 less than 70%, it has to be on PFT supposedly. Again, heart failure with reduced ejection fraction less than 40% is not a candidate, because we know that the incidence of central sleep apnea or complex sleep apnea is much higher in this subpopulation, and hence they may need something other than a CPAP. If they have failed a prior home sleep testing, particularly if they failed it twice, that is an indication for doing in-laboratory testing. Or if there's a concern for something other than straightforward obstructive sleep apnea, the periodic limb movement disorder, complex parasomnias, central apneas, seizures, these are patients who really should be evaluated in a laboratory. Next slide, please. In laboratory testing, again, we're using that particular EEG and the EOG. We're looking at things that the home sleep testing can't do. We also can measure insomnia much better, and since we have a video camera, we can tell if that insomnia is primary insomnia, if it's secondary to pain, or if it's behavioral. In other words, the patient just is looking at their phone or tablet or taking phone calls or gets an interruption in the middle of the night. We can also look at leg movements. We're also looking for the video monitoring can help with the parasomnias. Again, it may not be covered without a prior authorization. We have a team that does that. Several people actually can do that. This is usually a nightmare for the primary care doctors. You don't want to get involved in doing that any more than you have to. I totally understand that. I don't want to do it. And then there are also some options about doing advanced titrations for people who may need something other than a CPAP. For instance, a BiPAP ST, a BiPAP AVAPS, or a respiratory assist device at nighttime. Next slide, please. So the best thing I could tell you is if you order any testing, you're responsible for treating. We will interpret the test and we will send the patient back to you. Similar to an x-ray, we will say the person has this disorder and refer them back to you to figure out further testing and or treatment. However, if you send the patient to us in consultation, then we can address any other underlying sleep problems like sleep hygiene, insomnia, restless legs, give good sleep education, determine the appropriate testing. If the testing we order is denied by insurance, we will be the ones responsible for doing any denials or appeals and following them up, ordering the appropriate therapy, and then sending them back to you. We'll follow the patient in a short order if they're having issues, or if they're stable, seeing them probably once a year, depending on their insurance requirements. Some physicians, primary cares, ear, nose, and throat, even endocrinologists prefer to order their own test and treat the patient. I personally, professionally, have no problem with that whatsoever if you want to deal with it. Again, but if there's a denial of something, I will send the patient back to you for follow-up. Next slide, please. So things you want to do: get a good history, make a template out of it, don't spend time doing it, send the patient for testing plus consultation is probably going to be your best bet. If you're trying to get them in sooner, call or send us a message. If there's some reason why they need to be expedited, we don't mind doing that. Or just send them for a consultation alone and let us order the testing. There's usually more than one sleep disorder, and we can help sometimes elucidate that. One of the things you don't want to do is send them for testing, have us say it's positive. They come back to see you, send them for us for treatment, and months go in between or something happens and the patients fall off because they feel like it's not that important because it's taking so long to get to therapy. Next question. Excuse me, next slide. Going to end this. Next slide, please. Going to end this. This is an additional resource. This is by ResMed. You can Google ResMed pathophysiology, and this is a fantastic 12-minute video. It's kind of long for patients. It really does show how sleep disorder breathing works. It's also really, really good for practitioners. So if you have physicians, nurse practitioners in your office, front desk staff who hate sleep but they just don't understand it, have them watch this 12-minute video. It'll change how you see it. You'll be able to understand the physiology, what's going on, and I think you'll be able to give your patients better care. I think that's the last slide we have, and then I'll open up for any questions someone may have.
So I'll go ahead and jump in. We've got 2 questions in our Q&A box. And then I wrote down a couple things that I want to ask about. So our first question is asking if you could please talk about the new sleep apnea devices that have been approved by the FDA that are alternatives to CPAP.
Yes. So new devices, there are several on the market. So there is, of course, positional therapy, which can be raising the head of the bed, not new. And those sometimes can be even particular branded bolsters that go behind the back that kind of prevent you from lying supine. We know that patients who are lying on their side or who are lying prone tend to have less apneas. This is just a gravity issue. Your tongue, pharynx doesn't fall back and block off your throat. That's one option. Another option is this device called Excite OSA, which is a lingular stimulator. It's a little device you actually wear in the mouth. You put in the mouth, has a little dongle that hangs out. You wear it for about 20 minutes a day, every day for 6 weeks. At the end of 6 weeks, you cut back to just twice a week. It essentially shocks your tongue. It's like a TENS unit for your tongue. And what it does is it stimulates the tongue muscles, the pharyngeal dilators, to remain open so that even when you relax like a toned person, you have more tone. This has been FDA approved for mild sleep apnea, in other words, AGI less than 15, and for those with snoring and symptoms. It's not approved for moderate severe. It is not covered by insurance. It's about $800, but there are some rebate programs. We have coupons that can make it cheaper. There's a trial program, there's money back guarantee. And then there are the ones that people are seeing the commercials probably a little bit more familiar with, the hypoglossal nerve stimulators. Inspire is a big branded one. There's also a competition now that's in the process of doing clinical trials. We're one of the trial centers, so we do have 3 clinical trials going on right now for sleep, both for oral devices from Delta Dental and LivaNova for this hypoglossal nerve stimulator. This is essentially a pacemaker for the base of your tongue. It is a small metal box inserted under the skin on the right side of the chest, just like a pacemaker on the left side of the chest. There are 2 wires. There's a lead approximately that goes in between the ribs, the intercostal muscles. It senses chest wall excursion, sends a signal to the impulse generator or implanted pulse generator. That sends a signal out to the efferent lead, which will stimulate the back of the tongue muscles that's wrapped around the hypoglossal nerve to not only protrude the tongue, but in some instances also dilate the posterior pharynx. It can be titrated in terms of amplitude and frequency and timing. It is turned on remotely with a remote control the patient has every night before they go to sleep, turned off. It is approved for those with mild to severe, so an AHI of 15 to 60, not those with very severe apnea, in patients with a BMI less than 35, although that probably will change here in about 2 months. The BMI will be extended out to, I believe, 50, so we'll see what happens there. That is an FDA-approved device. It is covered by insurance. You do not have to fail PAP therapy anymore to be considered. And then, of course, there's upper airway surgeries, which can include things like septuloplasty, turbinate reduction, mandible extension. We very rarely do burning of the palate. What's called a uvular-palatal pharyngeoplasty, kind of burning off the uvula there. There are dental devices, which have both tongue retaining or tongue suction, as well as dental devices that can protrude the mandible to help with opening the airway. And then there are combination devices like a mandibular advancement device along with lingular stimulation. So there's a lot of options for patients, not just a CPAP.
So on a similar note, the next question has to do with the nerve stimulation devices, and would they help with sleep or with central apnea better than CPAP?
So for the Excito-SA, the little device you put in your mouth, is not indicated for central apnea. It has no effect on the brain. It's only affecting the tongue, so it won't help. The Inspire implant device, one of the contraindications is significant sleep apnea, so we need to have in-laboratory testing. Similar to the Inspire and the testing that we're doing here with the LivaNova device, which is called Osprey, there is one called Remedy, REMEDE, which is approved for central sleep apnea. It's basically the same thing as an Inspire with a little bit of a different lead behind it as well, and a backup rate generator. So that's a device that can be used for patients, particularly those who have heart failure with complex sleep apnea, and we know that their central apnea is making their heart failure worse. There is one other option. However, most patients with central sleep apnea, between stopping narcotics or reducing them, getting them on appropriate CPAP, if you give them time, let's say 2 to 3 months, their central apneas will actually go away. In other words, their brain will remodel as well as their airway, and they go from more having either central or complex to strictly obstructive sleep apnea.
Okay, the last question in the Q&A box, it has to do with the lab testing, the in-house studying of the sleep apnea. So the example given is we get a 24 to 48 hour Holter monitor to try and capture the palpitations. Will we be capturing the sleep apnea episodes if we're only doing one night?
Almost always. It is very difficult to fake apnea, in other words, to have it and then have a negative test. Now, the home sleep testing can underestimate the severity. So we do have patients who will come in and have a, quote, negative home sleep test, followed by in-laboratory testing and find out they actually have mild to moderate sleep apnea. So you're more likely to get milder symptoms, but one night is validated as much as 2 nights. This office personally, I never order 2 nights. Again, there's usually not much of a difference between the two. If one night is off and they have that many other issues, I'd rather bring them into the laboratory. But a Holter monitor will have no benefit. It will show irregularities, but it's not really going to show you much in oxygenation or, more importantly, flow. So if they're getting it for other reasons, great. But I say if they're having symptoms of angina, palpitations, overweight, over 40, you can get a Holter, but send them for a sleep study as well.
So couple questions that I had, just I think to sort of clarify for everyone participating. So if we're looking just by the history that we take, what would be a couple key things that people could take away to differentiate between the history you get from someone with central versus the history you get from someone with obstructive?
Difficult to get on a history, but the biggest question, which is the difficulty, is because patients don't really give you that clear response, is are there prolonged witnessed apneas? As you saw maybe in the first video, that guy clearly had a long period where there was no effort whatsoever. That's the biggest differentiator. Other things you have to look for are high risk. Are they pilots? Have they lived at high altitude? Are they on medications known to cause central apnea? So are they on chronic opioids or benzodiazepines or medications that can do that? But really it's just kind of either prolonged witnessed apneas or a loud gas, kind of a sudden choking or gasping, which would kind of suggest that there was a central apnea period followed by sufficient adrenaline that gives them to cross threshold and a big arousal, versus this kind of crescendo snoring where they snore, and then have an arousal. So if all of a sudden this kind of scares you because you didn't hear it, that could suggest it. However, sometimes that documentation, whether you're trying to elucidate central versus obstructive, is still not good enough to get it approved from insurance. And so I would say, although it's helpful for us, clinically we know what's going on, it doesn't do much for your changing whether or not the study is going to get approved.
Okay. Another question popped in. So asking if you could clarify the difference between CPAP and BiPAP.
So CPAP stands for continuous positive airway pressure. BiPAP is bi-level positive airway pressure. So positive airway pressure means it's blowing in your face like a fan. And so the way I describe it for patients is continuous is basically, it's like a dog having its head out the window of a moving car on cruise control. It's one pressure. Whether you breathe in or out or how often you breathe, it doesn't matter. It's going to blow at the same rate. That's a CPAP. Whereas bi-level has 2 pressures, and it is augmented to your flow. So when you breathe in, In other words, you're sucking in the pressure in the system drops, so it picks up the pressure some inside the machine. And as you blow out, it lowers it to maintain a constant range. So it's like having your head out the window in traffic or with a crazy driver. So that's the major difference between CPAP and BiPAP. There are several BiPAP advanced models where you get into backup rating and things that measure flow versus tidal volume versus pressure versus the time it spends inspiratory flow, or whether it allows a small decrease on exhalation. So a little trickier things when it gets to breathing on some of the more advanced models.
And I assume the tongue wagging outside the head in the window is totally optional.
That is optional.
So from a primary care perspective, should we look at the home testing versus within the sleep lab, much like we do with colon cancer screening, where we have Cologuard and some of the at-home tests that are good tests, they're valid tests, but our gold standard is still currently colonoscopy. And if you have someone that you deem at higher risk for colon cancer, they need a colonoscopy, not one of the at-home tests. So similar philosophy with this. If there's somebody that we see at higher risk for sleep apnea, we probably need to go ahead and get them sleep lab tested if we can get it approved by insurance.
I say yes and no. I think ideally that's what has been done in the past. The problem is it really is dictated because of the cost difference of $400 to maybe $2,000. It really is dictated by the person's insurance and your clinical documentation. I have a smart phrase. You're welcome to look it up. It's under my name. My initials KT. It's called .KT Contraindications. And it's a quick drop down. You can add your chart, which tells you the reasons why insurance will pay for an in-laboratory test. If it's clear-cut one of those, great. If it's not, if you think that they need an in-laboratory test, what I would say is if you're concerned about them, definitely send them for consultation. Because it's not just about getting them tested, then the key becomes also getting them treatment. Home sleep test is accurate in the vast majority. We probably do, 70% home sleep test now. The issue becomes if somebody comes back with mild, maybe moderate, straightforward symptoms, yes, I'm putting them on an auto-PAP. There's really no indication for doing a titration study in the lab to justify which pressure they're going to be on. However, if they have difficulty with CPAP titration, if they have claustrophobia, if they've had a car accident or they've had facial surgery, if they have severe insomnia, or if they have severe apnea on their home sleep test that was unsuspected. In other words, somebody's middle-aged, a little bit overweight, and I come back and they have 90 events per hour. I'm going to try really hard to get them in-lab titration to make sure that we get the appropriate pressure, because it's important we treat them, and I can't take the risk of them getting an auto-PAP and not liking it and getting it wrong. But yes, using your clinical judgment is huge, but it really comes down to the documentation.
Okay. Question that came in on the chat is, if someone has hypothyroidism, would you think they should routinely be screened for sleep apnea on a yearly basis, or just upon initial diagnosis?
I would do it upon initial diagnosis, and then after that, not based on that particular diagnosis, I would do it based on symptoms. So if there's symptoms like daytime fatigue, and that's one of the ones that kind of I've talked about, just briefly, fatigue versus sleepiness. I use that quite a bit. Some patients will say, I get up in the morning and I just don't want to do anything, and I'm kind of blah, but I don't ever really fall asleep ever. Like I never nap. And I don't get up in the middle of the night, and then I'm trying to tease out the differentiation. There's not a particular indication for doing repeat testing in somebody, especially once they're positive, unless they're having symptoms, massive weight gain, or new diagnoses like stroke, heart attack, heart failure, and you wonder to make sure that their CPAP is appropriate. But hypothyroidism in and of itself, once initial, I would not necessarily repeat it with any regularity unless their symptoms change.
Okay, and another question popped up in the Q&A. You mentioned central apnea can go away using CPAP. Should the patient be tested again after some months or time period of continuous use of CPAP?
So typically if they come in, unless they have overt heart failure or other signs of severe central apnea alone, if they have complex or we see that, once we start them on PAP therapy, we bring everybody back between 1 and 3 months. That's an insurance requirement to make sure, one, that they're using it, so they're compliant, and that it's effective. And one of the things we do with that report is we look to see the residual number of breathing events, the residual AHI. If I see the residual AHI is elevated, so it's greater than 5, or there hasn't been a 50% reduction, or inside the AHI, particularly the CAI or the central apnea index is above 5, or there's evidence of Shane Stokes breathing on that report, I'm going to follow that patient closely. I'm going to get a report every month, whether the patient's here or not. And if I don't see that index coming down after several months, we're going to bring them back in for a retitration to see if they need to change from a CPAP to a BiPAP advanced.
Okay, I don't see any other questions, and I think that, oh, here we go, one more. What do you think of having a patient with an MI or a stroke having a sleep study done before hospital discharge? That'd be something that we may want to look into to delay treatment.
That would be fantastic. The problem is it has to be outpatient in order for it to be covered. Inpatient sleep studies are not covered by any insurance. So although clinically it would be the best idea, it just doesn't happen. I have had coordinators call, discharge coordinators, say a patient is leaving the hospital tomorrow. Is it possible for them to pick up their equipment for even a home test, which again may not be ideal, but it may get them in sooner, before they leave the hospital? And we have instances we will literally walk it over, explain to them how to use it before discharge. On the night of discharge, they do their study and bring it back literally the following day so we can get them therapy as soon as possible.
Okay, so clearly that makes sense for us to provide inferior care based on insurance rules, but I know we have to deal within the confines of their rules.
Absolutely. But usually if they've had a stroke, the reason why I think that's a crucial way of doing it is you're touching the patient before they leave. You know, we don't realize sometimes how difficult it is for them to come for follow-up, and they're going to have several follow-ups scheduled.
Yes.
And so what I don't want them to do is to come for follow-up, do an evaluation, and then have to come back days later just to pick up the device. To me, that's 2 visits that I can stop with no visits by just getting it to them before they physically leave the building. So if you have a patient who's had a stroke, an ideal situation that was what would happen. We've looked at implementing that as a process improvement. Right now, we just don't have enough devices. We're ordering more. And honestly, I'll reach out to all the primary cares and say, hey, anything you guys can do to help, put pressure on administration for us to order 200 more devices because they're relatively cheap, would be beneficial for patients. And these devices pay for themselves in approximately 3 weeks. So the return on investment for the institution is very, very quick. But that's the system that we're looking to do. So we have done it in the past for several patients. This requires either sending a call to our office, sending me a message, hey, I got this person, I really need them to be seen ASAP. And if you have a patient in your outpatient clinic who needs to be seen urgently, we have space. We have multiple offices. So there's offices here at Brownsboro, Newburgh Road, Audubon Hospital, PRP, and virtual, as well as Southern Indiana. We have patients who live as far as, believe it or not, Fort Wayne. So we can see them usually same week with no problem whatsoever.
Okay, I do not see any other questions currently. I certainly appreciate the information that you gave, and obviously we had a lot of engagement with a number of questions and comments, et cetera. So I appreciate your time, everyone that took part in this.